Go ahead and get started. Welcome everybody to the Voucher Learning Collaborative. Thank you so much for joining us. There are a lot of new names on the list today. So welcome, we're welcoming new members as well as welcome back to those of you who've been a member of the Voucher Collaborative for a few years. All of you are muted right now, and we appreciate that very much, to keep yourself muted when you're not speaking. But please feel free to unmute yourself if you have something important to say. Oh, and Spencer's all the way in Mexico. I hope you're okay, Spencer. We're thinking of you. Again, welcome everybody. I'm going to go ahead and share my screen so we can get started.
I'll just say I'm here for a month for surgery, so I'll be back around soon. Just listening in.
Well, be well, Spencer.
Thank you.
Okay, again, welcome to the Voucher Learning Collaborative. I wanted to kick off the meeting today with just a really quick organizational meeting. Primarily because we lost a couple of our Voucher Learning Collaborative leaders this year. Linda Porter with Lifespan Respite Washington, who was really the original force, along with Ellie Billman from Colorado. The two original instigators of this wonderful Voucher Learning Collaborative have moved on. And then all the staff from the Colorado Respite Coalition have also moved on. But we have others who have stepped up into the leadership role. Nadine Walter, who's been on the Voucher Learning Collaborative for a while, brought on two of her partners from Sooner Success in Oklahoma to take the lead in leadership for this group. Unfortunately, as Aida just mentioned to some of us, Nadine has no electricity today because they're having an ice storm in Oklahoma. And I think Robin's not able to join for the same reason, but they're here in spirit, and Aita's here representing the Oklahoma team. And then Tracy Kalla with Lifespan Respite Washington has graciously agreed, at least for now, to help lead this collaborative as well. But we really would like to have an additional state represented, whether you're with a state respite coalition or a lifespan respite program, or part of the Arch Network as a respite program that's using respite vouchers. If you're the least bit interested in being a leader of the group, we'd love to have you. The primary responsibilities, and the time commitment is fairly minimal, is meeting just a few times a year so that we can plan out the schedule of webinars or calls and decide on the content for future meetings with your help. We want your input on that as well, but the Leadership Collaborative sort of helps formulate our agenda for the coming year. And also they've agreed to serve as mentors to those of you who may be considering starting a respite voucher program or need a little bit of guidance along the way. So we're extremely grateful for their participation. I had asked some of you to think about whether you'd like to join this group of leaders in the collaborative. And so I open it now for any discussion or questions about it. If you'd like to unmute yourself, because for some reason my chat is not opening up. And that could be because I'm on full screen here. So if you want to unmute yourself, if you think you'd be interested in being a leader of this collaborative, you can let me know now. Or email me later and we can talk about it. Or if you have any questions now, let me know. Anybody have thoughts or questions?
Well, Jill, just to echo what you've said already, honestly, the benefits of the collaborative are really important. I know we have certainly seen beneficial to the work we're doing in Oklahoma. And you're exactly right. In terms of the commitment, it's really been very complimentary, I'd say, to the work we're doing in Oklahoma. So if anyone is considering it, I would say, please come on board, because it is truly a partnership across states. And we have certainly learned so much from other states as well. I think it's just another level of communication that does benefit the work that we're doing.
Thank you, Aida. That's really, that's very helpful. Any other comments? Okay, we'll think about it. If I don't hear from anyone, I may be reaching out to a few of you who I think might make great leaders, and ask you to join us.
Yeah, it's Tracy. In the chat, someone came forward.
I don't know why I'm not able to see my chat. Let me stop sharing my screen for 1 minute. Let's see if that, yeah, that helps.
I could read it to you. It's from Marilyn, and she said she'd like to participate.
Oh, wonderful. This means being one of the leaders of the collaborative. So that's wonderful, Marilyn. Thank you. Terrific. All right, I'm going to go back to sharing my screen. Can you all see the slides if I leave it like this? Or do you like it better in the full screen mode?
I think full screen.
Okay, let me do that. I just for some reason can't get the chat when I do that. So anyway, for those of you who are brand new to the collaborative, we try very hard to meet 3 or 4 times a year as the full collaborative. And as I mentioned, the leaders meet a couple of additional times during the year. But we've had some really wonderful presentations by members of the collaborative. And you can access all of the past calls and webinars at that link that you see on your screen. I also sent the slides around to everyone this morning. So if you didn't access them, I will, well, I can't even post in the chat because I can't get to the chat. But I will send the slides around again after the call if you didn't see it. So you'll have these links as well, and you'll have Cheryl's slides. Another big activity that we undertook at the start of the collaborative was to undertake a survey of all of you. I think we had 16 states participate in our voucher survey, so we could get some real detailed information about how you implement your programs, whether they're true voucher programs or stipends or grant programs. And those results are posted on the Arch website at that link above it, where all of the Learning Collaborative information is collated. So that was a really wonderful activity, and we may consider redoing that voucher survey again so that we get some additional information. But we could not have done that without our Oklahoma partnership and some of the wonderful people at Sooner Success that partner in the Lifespan program, and Aita's wonderful graduate students who helped pull all that together. So again, another example of a great national state partnership that really benefited the collaborative. Okay, moving on. We have a lot of people on the call today. I'm seeing 39, so we may not do formal introductions, but we can see your names on the screen. If you want to type into the chat box where you're from and what your connection to voucher program is, that would be wonderful, and we'll have that information accessible to us. I did have a couple of polling questions just to get us started. So I'm going to bring those up now. The first one is, and this is just to get a sense of where you are with your voucher program given the current pandemic. I know some of you never stopped offering vouchers. Some of you completely withdrew because you had either a lack of interest on the part of caregivers or may have had some other restrictions about moving forward. And it would be really helpful now to get a new sense of how many of you out there during this pandemic have been continuing to offer respite vouchers, grants, or stipends to family caregivers. So I'll give you about 30 seconds to respond to that. Okay, let's share those results. As you can see, wow, a whopping 87% of you have been able to continue to offer your program. So that's fantastic. I really didn't expect it to be that high. And those of you who said no, were you, I guess a follow-up question would be, have you been able to offer any other kinds of supports to the family caregivers who you may have been serving through your voucher programs previously? If you want to unmute yourself and let us know that, or type it into the chat. And maybe those of you who can see the chat can read anyone's responses. Or if you said no, there were only 3 people who responded no, maybe it's because you never have even started a voucher program. That could be the reason as well.
Hi, Jill. This is Leanne Winchester from Massachusetts. So we've not offered a voucher program. What we have in Massachusetts is stipends. But when we're looking at the services in Massachusetts, you know, everything was closed. Day programs are closed, and it's the desperate need to find in-home providers has been difficult. Not only that there aren't enough there, but some don't either want individuals in the home, and then of course other folks don't want to go in because of the concern of COVID. So we're sort of like, I'm really looking forward to hearing from everyone, but that's just but I was one of the ones that said no.
Okay, that's very helpful. Anyone else? Let me launch the second question. For those of you that said yes to continuing to provide these services, since the pandemic started, has the number of vouchers, grants, or stipends that you've provided increased, decreased, or stayed the same? Let me launch that poll. Sorry about that. Here are the results. Interesting. For 4 of you, you've actually increased the numbers of vouchers that you served, that you've provided, and that's very interesting. I remember I went during the grantee meeting in June. I think it was Nick Swenson in Virginia who said he had an amazing increase in the numbers of caregivers requesting vouchers, and I thought that was really interesting because I would have expected the responses to be more along the lines of what Leanne was sharing, that family caregivers had fears about bringing someone into the home, or concerns about their loved ones and not wanting to take that chance and not feeling confident that their loved one would be safe with in-home respite services. But that's very interesting. For those of you who increased or decreased even your services, can you let us know if most of the family caregivers who are using the vouchers are using in-home services or out-of-home community-based services? Because we have learned there are increasingly some community-based respite services that have reopened their services as well. Again, if you want to unmute yourselves and tell us about your experience or type it into the chat box.
Jill, it's Tracy.
Yeah.
So I think we've been sharing that initially, again, everything shut down for us in Washington State in March. So pretty much from March 23rd was our state stay-at-home order. And we definitely saw that March through about August. And that's when I think families were getting their minds wrapped around. The majority of our folks do request in-home, and we did another a large amount of awards in that time period. And now we're pretty much every other Friday able to review. We were the state without Linda Porter for that amount of time. So now we have our full-time person back. We've chunked through the review status and have been back in the flow of being able to award. We've always been there to be supportive, but I think families were just, it was really, as I think we're all experiencing, extraordinarily difficult to think about someone coming in and what would that be like. And so now we're starting to see, families. I had one mom in particular make a comment that I thought was, brilliant on her part. She was saying, well, wait a minute, if this person comes in and they can do some baking with my, daughter with IDD, then I could go elsewhere in the house. And I'm like, exactly. And she was like, oh, that'll be so great. And she'll love having her own time and somebody other than myself. And, they were just really, they're very hunkered down and, and obviously for all the good reasons that people are trying to stay healthy and well. So thank you for letting me share.
Thank you. And thank you for introducing yourself as one of our collaborative leaders along with Aida from Oklahoma. Thank you both for letting people see who you are. Okay, thank you all for responding to those quick polls. I just found my chat. Yay. Let's see what we've got in the chat here. Linda Wolf in Missouri is providing mostly in-home. North Carolina, Lisa says the number of vouchers have stayed basically the same. But with CARES funding, yeah, that's an interesting point. For those of you who had CARES funding for the National Family Caregiver Support Program, that may have helped you increase the number of vouchers that you can provide. Wonderful. And I see Lori Stahlbaum, our Lifespan Respite Project Officer, has joined us. Welcome, Lori. Okay.
Hi, Jill. Hi, everybody.
Welcome. So moving on to our organizational meeting, we already discussed the importance of our collaborative leaders, and I've made the pitch. And we've had Marilyn Sword from Idaho step forward, so we're very excited about that. If there are additional people who would like to be leaders, we don't have a limit on the number of leaders we'd like to have. So again, if you think it's something you'd like to do, just let me know, put it in the chat or send me an email. I just really quickly wanted to talk about some future focus areas that we might want to hone in on with future calls. In the past, we've talked about everything from liability issues to how programs are actually implemented, whether funds go to caregivers or to service providers, whether programs are self-directed or consumer-directed, or a little bit more prescriptive than that. We've just covered the gamut, but if there is a particular topic or issue area that you'd like us to focus on, let's talk about it now, or let me know. Anybody have any issues they'd really like us to focus on the next few meetings?
Jill, I have one to consider.
Wonderful.
With COVID, we're not in person, and we rely heavily on community events pre-COVID. And so it's really the outreach piece and really trying to connect with new caregivers. Thankfully, the caregivers we've already served, they are eligible to renew vouchers every 4 months. And so we hear from them in most cases, or at least a high percent. It's really trying to reach new caregivers during this time, since we're not doing in-person community events. I would just love to see and learn from others. Obviously, other caregivers tell other caregivers, and that has certainly helped. And social media, we're utilizing that. So it's really outreach to caregivers that perhaps aren't relying on internet and maybe have even some limited internet access that I would like to hear from others on.
I think that would be a fantastic topic for our next call, especially with all the issues that you just raised about the pandemic. And not being
And Jill, this is Dina from New York, and we actually, we had a few requests from our area agencies on aging pertaining to our National Family Caregiver Support Program funds. And I did reach out to ACL just to see if, you know, they had other states that maybe inquired so that we could see if they had put out any guidance. And in talking to Kathleen Addy, you know, she had kind of recommended going to Arch and to Lori, and I was like, yes, you know, we researched all of that. So it does seem to be a widespread interest. So I will just share that in some of that exploration, we came across that there was a virtual health fair that was done that had like a family caregiver component that AARP was involved in. So we did actually connect with them. In fact, the Department for Aging in New York City was able to connect with them, and they actually did get some information just about how they went about holding a virtual fair, which I thought sounded, you know, it sounded kind of cool. From the little bit I, gathered from the conversation, it seemed like it almost was where somebody could raise their hand and be allowed to come into a room, but it would be one-on-one, like somebody coming up to a table or a booth. So I thought that was kind of cool. So we're still in the midst of exploring it, but I just thought I'd share what we've learned so far and just to voice that it seems to be a need in our state as well.
So your suggestion for a topic might be alternative respite options to the voucher programs we're talking about today. If states are not able to offer their vouchers or stipends or grants. So that might be.
Yeah, well, I guess that, or I guess I'm saying that I think the outreach is a big piece of like finding new caregivers.
Right.
Yeah, so that might be one way to do it, is like if you were able to host a virtual fair and partner with somebody. I mean, our state isn't doing vouchers yet. We're here to learn because we're planning to do them. But I'm just thinking, like, regardless if it's vouchers or whatever services that you're able to offer your caregivers, you know, like reaching them right now is difficult too. Even if you are able to serve them, you know, getting the information to new caregivers, I think, is challenging. So
Yes, no, that's a great idea. Okay, I understand now.
Jill,
Yes.
Lori, one of the things I'm learning, hi everybody, learning too is that as things are kind of ebbing and flowing, and some states are doing, you know, better with the pandemic, the COVID, and some are becoming new hotspots and what have you. For the ACL Lifespan Respite grantees, as Lynn pointed out, the match can be difficult. And I don't know that this is a place for that, but in light of all of the things going on, if that was a topic of we have not had any early on in the pandemic, back in March and April and May, the Department of Health and Human Services Grants Policy Office was putting out all kinds of memorandum, giving us some flexibilities, but we have not had any new flexibilities or memorandums, as informational memorandums, as they call them. But I do want to let people know, you know, we can talk to the group or Sherlonda Blue, who's our grant specialist, or to remind people that, you know, we're here to work with folks on those obstacles, because what used to be in-kind match, like a meeting room, isn't happening anymore. And so I hope that's not too detracting, but I saw Lynn's comment in big cap letters. So I know, and I do know it is an issue, and it's something I want people to rest assured that despite not having special approvals, we still can work with folks and be flexible. And I also had an idea about reaching new caregivers. Oh, you're welcome, Lynn. Reaching new caregivers if in this in here, also because of unemployment and that sort of things, we have a lot of people having to go to food distribution sites and things like that. And the library, if there's a way to going non-internet, and I'm sorry if I mispronounced your name, Aida, is that correct?
Yes,
Yeah.
that's correct.
Okay, thank you.
Thank you, Lori.
You're welcome. Without going high tech, if the libraries aren't open, some of ours are, some of ours aren't. They've got small numbers open, but working with a librarian, or if they could be put in a food distribution bag, just something. And then November coming is National Family Caregivers Month, so there's going to be some of the stuff is going out, but we've talked about in other things, a big deal is people identifying themselves as a caregiver. Are they coming? Are they not coming? I know it took me a long time to realize I was actually a caregiver, not just, a regular old Lori. But I was just thinking about all the different things they're doing here to try to help people. There's a way to get your synergy in with that, just like that one state that has those little flyers or a little card or something that takes the high tech out of it, which I think would mostly be operated by the states, local governments, or the community, community nonprofits. And I'm sure there's it's just my thought. Thank you.
Yeah, that's a good thought. As you raise that, Lori, I'm also thinking about utility companies. And you're right in terms of identifying as a caregiver. I think it's certainly true for those that are new in their journey. They may not be as familiarized with caregiver. We are planning a statewide virtual conference for National Caregiver Month in November. And so we've successfully have hosted virtual events, and I think they have been great. But you're right, Lori, it's really how do we reach those that have limited access to internet or maybe no access? So I think you're raising some good ideas too, in terms of looking at partnering with even the schools that are continuing to provide, even if they're doing virtual learning, they're doing the lunch programs. And so those are good thoughts, and it got my wheels kind of turning. And that's exactly why this is so important, is that we're learning from each other, and it helps us evolve those ideas to then have next steps. So I appreciate those thoughts. So thank you, Lori.
Oh, thank you.
Well, these are some great ideas for future meetings. And if you think of anything else after you log out of this call today, again, just send us an email, and we will take it up in our planning call with the leaders, which we hope to schedule in the next few weeks. And then we'll be able to send you a schedule of calls, hopefully, for the remainder of the project year. Okay, without further ado, we'll first hear from Cheryl Dinnell, who's going to give us a wonderful update on their Nevada Respite RX program, and then we'll close out with questions and answers. And if any of you have additional updates at that time that you want to share about your own projects, we'll move on to that. But right now I'm going to turn it over to you, Cheryl. Cheryl Dinnell, who is the project coordinator in Nevada for their wonderful Respite Voucher program.
Good afternoon, everyone. Today I'm going to be sharing some information from our Lifespan Respite Care program administered by our Nevada Aging and Disability Services Division. And then I'll just ask Jill to just go to the next slide. We'll get started. For those of you who are unfamiliar, I saw in the chat that somebody had put down some information for the webinar that we did, gosh, a while ago about our pilot program, but I'm going to provide just a really quick overview of what Respite RX. It's a voucher demonstration project for respite that's funded by our Lifespan Respite Grant. And of course, respite is that break from caregiving and necessary for self-care of the caregiver. And to get a break, a caregiver needs to be able to turn over care to somebody else, hopefully someone dependable, reliable, capable of providing care in their place. But respite breaks can be created in many ways. So for our voucher program, the respite experience was tailored to the caregiver through a person-centered approach. So the goal of of this pilot program was to get caregivers to recognize the need for respite for themselves, and then to remove as many barriers as possible to get them to use it. Respite RX was also designed to fill gaps in respite services, especially to address needs in rural Nevada, as well as for families caring for individuals between 18 to 59 years of age, which keeps showing up as an underserved population. Respite RX was designed to be self-directed, meaning the family caregiver would be given more choice, flexibility, and control over the design and delivery of their respite service, and more responsibility too. Respite RX also had several unique features we wanted to test. One unique feature was that the caregiver qualified for respite. It is not based on the care recipient's eligibility. And so through a person-centered planning process, family caregivers were able to design respite to fit their needs, lifestyle, preferences, as much as it could be found in their community. The goal was to give each caregiver a regular dosage of respite for a full year and to experience with them the opportunities and challenges they would encounter during that year, so we could learn those aspects as well. In designing how respite fit best with them, caregivers would describe some goals for respite: to see friends and family, get away for some time on their own, enjoy activities that were meaningful to them, and hopefully envision their return to caregiving feeling more relaxed, rejuvenated, and mentally and emotionally strong. Next slide. And this pilot program has been generating lots of data for discussion and consideration, and I only have time to touch on a few points today. We have done our best to adjust to changing circumstances and watch to see how our original premise for the design of Respite RX, how it held up during the COVID-19 pandemic, amongst other challenges. Now, we're learning a great deal from our family caregivers and have gained a greater appreciation of their role in our system of long-term supports and services. From research studies, we learn that caregivers are more aware of respite, but are still not accessing it. Only about 14% of caregivers reported using respite. So why is that? In our Respite RX program, 36% of caregivers surveyed said they needed more choice and flexibility in the design of respite. They wanted to hire friends or family as their respite workers, or schedule respite for when they could best use it. So in Respite RX, we refer to this as part of finding the respite fit. 81% of our program participants identified the limited options in-home care as a barrier to seeking respite. Sometimes the option was limited to a single vendor in a community, if there was one at all. And vendors of in-home care often had policies about minimum hours or did not have staff who could fill all service requests. And getting a vendor to send staff to an unsupported rural community was extremely difficult, especially if travel times would be significant. Related more to the facility-based respite programs, about 25% of our caregivers were looking for after-hours care, especially on weekends. And 25% were concerned about emergency care options they might need to use. Even extra steps such as TB testing added to the delays in their being able to access respite. Next slide. One of the first lessons learned in our program came from the long-term care community. We got challenged on who we served, and the question of whom do we serve became an important one to address. We chose to serve the caregiver, so the eligibility of the care recipient was not the driver of service. This was completely outside the norm in the long-term care community, where everything else was determined by the eligibility of the care recipient. Typically, all funding for respite is tied to care recipient benefits, such as an individual with disability, a disabled veteran, or someone with a specific healthcare condition. But it certainly changes the focus and priority of respite services. When it comes to data, that's why we know so little about our caregivers and know so much more about our care recipients. With Respite RX, we decided to honor the premise that respite was meant to benefit the caregiver. So it's interesting to be part of a gap filling program for respite. What are gaps? Do funded programs that serve older adults have the reach to serve families of older adults everywhere? Do caregivers not need respite unless they fall into a low income bracket or there's the right diagnosis at the right age? What if a caregiver's need for respite does not fit an existing program's hours or availability? And since we were open to gaps, programs were soon sending us their waitlist families. We had also participants trying to benefit from respite under more than one respite program because just one model did not meet their unique respite needs. So was that double dipping? Other participants were told they would risk services to their care recipient if they accepted respite under our program, which was so bizarre. They had to choose between themselves and their loved one. And this caused really confusing messaging to our caregivers who were attempting to utilize respite. As we're responsible for designing respite, are we also responsible for creating barriers, challenges, and hoops to go through so a caregiver can even benefit from taking a small break? No wonder it's not worth the hassle for some caregivers. Getting caregivers more hours was never the priority. We were always striving to recognize the barriers to respite and working to help caregivers get respite they could and would use. But this certainly became a significant issue between programs, and we're going to need to further work collaborating and coordinating amongst those in our respite network. In designing respite, we in the long-term care community make a lot of decisions for caregivers as we manage the funding and resources for respite. What is the right amount of funding to provide? Who is should be the right type of provider for care? What is the right amount of respite hours or the time frame to use it in or the rate of pay for the service? And how well have we considered the caregiver need in our offers for respite? Designing respite comes with a lot of unanswered questions when determining what would be beneficial to caregivers. What is important to them? What do they need from us to help them reach their goals? In Respite RX, there was a person-centered respite design session with each caregiver to talk about their life, their schedule, their resources, and their desires. We asked them, what would it take to get them to use respite and to take that time for themselves? And here's a quote from one of our program participants. "It was nice to have someone ask about me. I don't think anyone has ever asked before." So in Respite RX, we watched to see what caregivers would do as they self-directed their respite service. There were a lot of requests for weekends, either a chance to go to church or spend time on mini trips, whatever. And I even had caregivers looking for help at night so they could just sleep. So how did they use the choice, control, flexibility they had over their respite service? They hired a lot of family and friends. If it wasn't working out with their current respite provider, or they fired one and hired another. So self-directed really just seems to be a good answer for many of them. So some of you may be wondering, how did we determine our budget for respite? We did reference studies on the effective use of respite that ARCH had to determine our approach to provide caregivers with a regular break of approximately 2 to 4 hours per week. We obviously had a dollar amount to work with, but based on that goal and kind of a stab at what we hoped would be the average cost per hour, we were able to determine how many participants we could serve in our program. Caregivers negotiated the rate of pay with the worker or the provider of their choice, considered the cost differences of hiring individual workers or using an agency provider, and determined how those respite hours would be grouped each month. We didn't control that. They could use the hours all at once or spread them around. They may not have felt that the roughly 2 to 4 hours a week was enough, but we wanted to at least give them that. Next slide, Jill. One before that, Joe. There we go. As we wanted participants to get a regular dosage of respite, we looked at the demand for respite as they participated in our program. And we had 3 places to assess the demand. At the time of referral and application, in the pre-respite survey that we conducted with them, and during our respite design session. Not surprisingly, the demanded application, and that's the blue line on the chart, where they were asked to provide the ideal number of respite hours per week, was much higher than the other measures. It was an open-ended, fill-in-the-blank answer. The majority requested 9 to 12 hours on a weekly basis, but some requested 40 plus hours a week, as much as a full-time job, for respite breaks. So it sounded like caregiver burnout to us. When we asked in the pre-respite survey, how many hours per week of respite would benefit you, we did provide a limited scope of answers. 2 hours or less, 2 to 4 hours, 5 to 9 hours, and 10 plus hours per week. And there were several requests for as many hours as possible that was written in. But with these limited options for making choices, the results are now on the red line. And it leveled out significantly. The 10 plus hours still got the majority again, but the average fell from 14.7 hours, which was the blue line, down to 6.6 hours for the red line per week. And then we engaged caregivers in that person-centered planning process to figure out how respite would fit into their lives. And then the requested hours fell significantly again. Caregivers were encouraged to think of what they would like to do with their respite time, and they thought of activities they wanted to engage in, but they struggled to figure out how to fit that into their lives. I think it's possible that the commitment to rebuilding some of the aspect of their life was one reason the numbers fell. It wasn't, going to be easy for them to step away from their caregiving role, or easy to regain the relationships that maybe had slipped away. One other thing we noted was that caregivers selected the easiest caregiving times of their day to take their break. So the majority fell into the 3 to 4 hour block of time, and the average fell to 4.4 hours per week, and that's the green line. So this fits that initial recommendation on effective respite we based our planning on. The next piece of data that we're going to have to add to this picture will be the usage data. And given that they had a planned respite designed for them individually, we want to see, did they use it? Or how did they group those respite hours? Did they do it as they had planned? We're getting that data now, but we won't have a full picture until, of course, our program participation ends, which is in December. Next slide. Okay, in case you were curious about what the hourly cost of respite ended up being, here's the numbers. Our working hypothesis of an average of about $15 an hour was pretty much spot on. The range was from $8 an hour to $26 per hour, with the average being 14.49, and that's statewide, urban and rural. Go ahead and next slide. Respite programs have also always had a really high dropout rate, at least in our state. I think that's pretty much nationwide, and no one really knew why. And so we wanted to know what caused people to exit our program, and here's our results. So looking at the pie, the orange section, we actually became alarmed early on when we couldn't get people into our program fast enough, and death had claimed their loved one before they could get any respite. For many others, death prevented us from giving caregivers that full year of respite experience like we'd hoped. Caregivers would say, I don't know why I waited so long to accept respite, because it has been wonderful to receive. But as a result, we feel strongly that we need to catch caregivers much earlier when we're offering respite supports. That message of how important respite is still needs to get out there. Understanding respite, however, was an issue. In that yellow section, we had applicants who thought respite workers were housekeepers. Respite would cover them while they were working, or some other service type. So respite was the wrong fit, and we had to redirect them to resources we knew about or back to our Nevada Care Connection for referral. And there were also several who simply just moved away after applying to our program. So as displayed in the purple, other caregivers had to make hard placement decisions for their loved ones. The more troubling was where families were too stressed to complete the process, and those were in the blue box on the side. Some caregivers knew they needed respite, but the care recipient would just not allow them to accept it. Others were troubled by the responsibilities of a self-directed respite program. They were deterred by the need to find and hire their own respite worker. They would say, don't you just send someone, was their typical response. And we tried to assist as much as possible, even help caregivers write job ads for the respite positions they were creating. Unfortunately, as a GAP program, Respite RX was likely the only option available to them outside of private paid respite. They simply could not move forward. Some did balk at the paperwork or the information they would have to share, and we tried to assist as much as possible, spending even a specific session with them to walk through the forms they needed to complete. While they wanted respite, they didn't want to do the search for a respite worker or provider. And we had caregivers say they would never hire a stranger, and not even one sent out by an agency, but they didn't have any friends or family they would hire either. Kind of hard to move past these barriers. Whether the lack of reply category, that's that green box, were people overwhelmed by the process, unconvinced they needed respite, or facing a barrier we might have been able to address, we'll never know. We do have a very transient population. Trying to keep tabs on these applicants was a difficult job, but I think we have a much clearer picture of the real drop-off rate and can develop some strategies to address the situations that occurred in the future. The self-directed respite model piloted during our current project was successful for families who would not have otherwise accessed respite. However, it also highlighted some new challenges in caregivers accepting respite. We did have to provide a higher level of case management support to our caregivers than most voucher programs expect to provide. The respite model of self-direction was probably not a perfect solution on its own, particularly because families have become so isolated and disconnected in their communities that they have no one to call on to provide any help. As we learned during this grant, families need significant support in connecting with respite worker resources. According to the report Caregiving in the United States in 2020, approximately 29% of caregivers who are the sole provider of care reporting having no sources of help or the information to help them find services and supports for themselves and their care recipients. And Nevada families were no different. Connecting families with respite workers and providers is a huge need we struggle to meet. We were building connections as fast and as quickly as best as we could, but our outreach on behalf of caregivers was not successful in every case. how to attract workers, how to make workers and providers feel more like friends so that caregivers and care recipients will allow them to share the care. Hopefully those will be the focus of future respite programs or projects for our state. Next slide, please. Okay, the commitment to care was extremely high amongst our participants. Most have provided 1 to 5 years of service already, so they were almost all long-term caregivers. But their confidence in how they were doing as caregivers was surprisingly low. So comparing the years of caregiving experience with the worries and caregiving concerns of those caregivers committed to providing care kind of appeared that all caregivers feel they should be doing, should do a better job. And that's the orange bar in the chart above. All are above 60%. So confidence there is missing. Also, the sense that they should be doing more for their loved one increases in time with time in caregiving. And those are those gray bars on the chart. So again, all at or above 50% of our participant pool. So this is a concern, obviously, because if we truly see caregivers as a lifeline of care in our long-term care system, do we need to address this? If an agency saw that their staff had these levels of worry and concern or lack of confidence in doing their jobs, what would they do? What do we need to do to address this for our caregivers and make sure that they are supported? One would be maybe offering training in care skills or different strategies for addressing care. But I didn't have a single caregiver take up offers for training, even if we could arrange it for them and their respite workers. Actually, our data shows that their interest or their need for training and caregiving strategies decrease slightly as their years of experience increase. And so you can see that on the yellow bars that are on the top of each stack. And their worry and anxiety appear to decline as well, which are the blue bars on the bottom of each stack. So it helps to offer these training and skill development opportunities to caregivers early on, but it seems to be missing a bigger picture if they won't readily accept it. Of course, there are reports nationally that caregiver support groups and caregiver support consultations are more effective at reducing worry and stress among caregivers than training and skills development. So how do we incorporate that in respite programming? Here's something else to think about. The next slide. Caregivers who are seeking respite, and that's that green line on the chart. When the care levels for activities of daily living and instrumental activities of daily living, those are referred to as ADLs, IADLs, was relatively low, as indicated by those blue and red bars at the bottom of the chart. So there isn't a strong correlation between what care demands required of them and their interest in respite support. One thing our data does suggest is that the demand for respite begins to build when the care assistance needed really is starting to increase. So the peak demand for respite was when only 39% of our care recipients, ADLs, IADLs now required assistance. Caregivers were already certainly starting to feel the impact of care on their lives. So we are looking for what matches more consistently with those referrals. Next slide. Okay, this chart reflects the care burden, those, Zurich care questions that are placed on the shoulders of our caregivers. The impact of caregiving on the life of a caregiver shows a more consistent need for respite on that upward trend when caregiving takes away more and more time for self, time with family and friends, time for enjoyable activities that would refresh and revive them. The bars on the bottom show the impact of no time for self, no social connections, no help with care, no choice in activities, and seeing relationships hurt because of caregiving demands. So damage to relationships may be due to just never being able to see one another or investing the necessary time and keeping close, because caregiving has become, of course, the main focus of a caregiver's life. So this was consistent, seems to be more consistent with the longings expressed in the respite design sessions with the participants when they were asked the following questions. What would I do if I had a break from caregiving? And who would I spend time with during a break from caregiving? And this longing with sadness does not diminish their caregiver commitment to care, because whether driven by cultural or moral or familial reasons, our caregivers were fully committed to care, but they just sacrificed everything that keeps them going. It's like they put themselves in the driver's seat of a vehicle to drive forward for as long and as far as they can, but they can't stop to refill the tank. They would do so if they could, but on this road they're on, there's really no place they can pull in to stop and refuel. This is the correlation for respite services we need to understand. Others would describe this longing with sadness as loneliness. So does that fit our caregivers? Next slide. Loneliness is an indicator of social well-being. It is the feeling of missing an intimate relationship, referred to as emotional loneliness, or missing a wider social network, referred to as social loneliness. Loneliness is the sense of suffering from being disconnected from other people, which is different than social isolation, which is simply not being around other people or not having close connections. Does this sound like what our caregivers have been struggling with? People who have moved to a place where they are newcomers frequently report social loneliness. Well, that's Nevada. Hello, welcome to Nevada. Very common here. Some emotional loneliness arises when a care partnership relationship kind of disintegrates through the effects of disease and disability, and is characterized by intense feelings of emptiness, abandonment, and forlornness. We found evidence of both these types of loneliness in our data. Is respite the right answer for loneliness? We call this our best test case, the COVID-19 pandemic. Next slide. Like everyone, nationwide, Nevada was impacted by COVID-19. We saw providers shut down, limit their services to only essential services, or shift to other activities to help bring caregivers and their families some relief. Here in Nevada, we acknowledge that unpaid family caregivers are a huge part of the long-term care support system, but caregiver support such as respite are considered a non-essential service, despite the size of the workforce it supports. So how did our Respite RX program hold up? About 48% of our participants, that's in the blue, dark blue in the pie chart, did not see any impact at all because, well, they usually hired family or close friends who limited their risk of bringing germs to the household. Also, a few providers, vendors continue to send workers under strict service policies to mitigate risks. But some said our respite service was the only thing they were still receiving, especially at the very beginning of our pandemic. About 45% of the participants, and that's the green half of the pie chart, did see impacts to their respite services. Of those, about 19%, that's the light blue box at the side, self-imposed or suspended services over COVID-19 fears. Another 26, that's the yellow box, had program closures, respite workers under self-quarantine or impacts to respite that their plans were, because of event cancellations, business closures, travel restrictions didn't happen. Those who had respite throughout the COVID pandemic fared far better than those who had to restrict their access to respite or who lost their access to respite due to program shutdowns or restrictions. Mental health supports against risks such as compassion fatigue were mostly displaced by emergency response for food, medical care, and PPE. I said mostly because there were signs that caregivers did get some care that they desperately needed, but I don't think we realized what it is that we did right or why it was so important. If we're to learn anything from our COVID-19 experience, I hope to highlight what is fundamentally important to caregivers and have us remember this as we continue to serve and support caregivers. Next slide. Okay, so when government advised self-isolation and announced some stay-at-home orders to stop the spread of COVID-19, millions of us lost a million little social outlets, while temporarily sacrificing our socializing to slow a worldwide pandemic was a choice and a trade most of us were certainly willing to make. Our society saw record calls on suicide hotlines, spikes in domestic violence, alarms raised on every health measure we track, on depression, anxiety, eating disorders, everything, you name it. We already had research studies on loneliness from back in 2010 that found that these relationship impacts to our physical health were so profound that chronic loneliness and isolation can be as dangerous as a pack-a-day smoking habit. Loneliness can shorten lifespan by about 5 years. Interestingly, caregiving long-term is known to do the same. So the loneliness studies, their big reveal, social disconnection turned out to be far worse for health than big name problems like obesity, alcoholism, pollution, and it beat out factors like high blood pressure or cholesterol levels. So it's people who don't have, strong support mechanisms. So think of our caregivers' need for trusted friends and family members persistently experience poor outcomes. That's scary because loneliness is nearly a universal experience that crosses borders and cultures and can affect us as easily as when we're in a crowd as when we're alone. And now, for the first time in a long time, caregivers feeling stuck at home had something in common with their peers who were not necessarily caregivers, but were now equally stuck at home. Everyone had to figure out how to do things when no one could leave one's home without jumping through lots of hoops of prevention and precaution. While loneliness is not a mental health condition, those who already grapple with depression or anxiety are, of course, at a significantly greater risk for experiencing loneliness. In turn, loneliness and isolation can just exacerbate, existing mental health challenges, kind of forming a vicious circle. Interestingly, loneliness is a perception, and not everyone who is isolated or even lives alone feels lonely. But in times of uncertainty, hello, coronavirus, we're more likely to crave the reassurance of a connection. When we can't find someone close to offer support, loneliness enters. It's uncomfortable to discuss loneliness. No one wants to become an object of pity. There's a lot of stigma and shame around loneliness, and a lot of people don't want to admit it. And we didn't even ask about that in our studies as well. But loneliness could be thought of as simply a biological imperative, like hunger. When you feel hungry, it's your body's way of saying, hey, it's time to eat. Similarly, loneliness is your body and mind's way of saying, hey, you need to be around people. And most caregivers are feeling a hunger for social connection. But the silver lining of the COVID-19 crisis might be highlighting just how devastating social isolation really is. Maybe the coronavirus will be what finally makes this clear in our support for respite programming. Through the pandemic, we have all been given a taste of what it's like to be cut off from loved ones. But for family caregivers, loneliness and social isolation was pretty standard experience well before the social distancing and sheltering in place aggravated kind of the problem. I had caregivers say, "We've got this. We are experts at social distancing." But even after COVID-19 is controlled, loneliness will be the shadow pandemic that remains. Here's what I think we did right. Regular contact to check in on families, caregivers, and also our staff and volunteers has been the right COVID-19 response. The food and supplies were necessary and appropriate relief, but the contact we made, I think, was truly life-saving, letting people know that someone cares. I came across this quote: "One of the greatest gifts we can give other people is the gift of our full attention." And I certainly think our caregivers deserve to get more of our attention. Next slide. Another area we had struggled with during COVID-19 was health literacy, because during a pandemic where solid information wasn't readily available, misinformation was rampant. But health literacy means caregivers and care recipients have the knowledge and decision-making skills to know how to address the various health impacts experienced, such as during the COVID pandemic. Instead of having that confidence, families tended to avoid all risks instead of mitigating them and making solid judgments on the services they would receive and accept. We had worked really very hard at getting caregivers to use respite. And I just talked about the negative impacts that come with loneliness and isolation. The COVID lockdowns did not help us much in addressing the underlying need for respite. Thankfully, we're getting some tools, some valuable tools now through ARCH and through some of the outstanding work done by some wonderful professionals to help provide agencies and caregivers with some decision-making tools so that they can carefully consider both the caregiver's own needs, again, balance against the needs of their loved ones, and start to deliver services or allow caregivers to regain the respite services they still desperately need. It's hard to see families experience the fatigue, frustration, the anxiety, aggravated health conditions because they could no longer access the respite service they once enjoyed. It's kind of like stuffing them back in the box when you were the one that finally let them out. And it was so hard to see families so scared of making a wrong decision regarding their loved one. They again were making all the sacrifices as they committed to stick it out at home for as long as it took. In a world, in our world, the respite world, I think a valuable long-term care workforce is at risk if we don't take their needs seriously. And I hope we won't leave them feeling alone anymore. Next slide. If you would like more information about our program or receive the final report on the pilot when it's finally available, just give us a call, contact us. We're in the final months of our program and certainly know plenty of work on defending respite funding still lies ahead. We'd love to hear from others who have data and studies on improving respite services for caregivers. There's still a lot to learn. And we'll hopefully have some more information this year as we finish up our project. So thank you.
Thank you so much, Cheryl. That was such an incredible presentation. And I'm so glad that you were willing to share this with us, even as your project wraps up. We hope that we will see that final report, and maybe you'll be able to come back and share any new data that comes out of concluding the study. But that was wonderful. Does anyone have any questions for Cheryl?
I just want to say thank you. That was riveting. You did a great job. The information was really helpful. Thanks.
Absolutely.
I had a question.
Jill, you had somebody who was doing a loneliness questioning in their packet. I can't remember what state was doing that. Who was doing it? We didn't ask any really loneliness questions. We're deriving our data from the burden surveys and stuff, but somebody was doing actually some loneliness questions.
I think New York State, Dina, didn't you share that with us, that there was a loneliness assessment being conducted through the caregiver programs?
It actually, yeah, I did share it, and it was something that we piloted way before the pandemic, to combat social isolation. They did a pilot program and it accompanied the companion pets. But we, are using the loneliness scale tool, and we can certainly, I think you posted it, Jill, too, if I remember, on the ARCH website, but we can share that again if it's helpful. But I know that everyone is, everyone is using it, and I think it's been shared pretty widely now.
Well, that was one thing we didn't know or think about doing when we started our program. It's too late to go back and kind of capture that, but would be interesting if you had data to share on that. I'd appreciate it.
Yeah, there was some anecdotal data shared, but we could probably get some more specifics, if that would be helpful. I can check into that because we didn't run the pilot. It was actually, I think, through the Association of Area Agencies on Aging, and that was, I think, almost 2 years ago that they did that. But we can certainly request that information.
Yeah, we'd love to see that. Linda Wolf commented, and I have to agree with her here, that she says over her 36 years of doing respite, she's seen many of the same findings that you found, but they've never captured the data. And I think that is so compelling about the work that you've done in Nevada, that we finally have this incredible data in detail about the services you were able to provide, and with the goal being to improve access to services and the quality of services. So very timely and exceedingly important. I'm looking through the chat now to see if there are any other questions. Just lots of praise for an excellent presentation, Cheryl. Aita in Oklahoma, you can ask this question if you want to unmute yourself.
Hi, I just was curious, I may have missed it, I apologize. How many participated and how long did they participate?
Our participant pool was 60, and the goal was to give them a year's worth of respite, which was quite different from some of the other programs in our state that do kind of incremental, either 3 months or half year kind of funding for respite. So the goal was to kind of see what was the fallout reasons. We needed to follow them long-term to find that out. And also to find out what some of the other barriers they really were experiencing under this kind of self-directed model. And so that's been very eye-opening. It is frustrating when you're overwhelmed caregiver to have not just the natural option land in your plate. You really got to do some searching. And we wrote, like I said, job descriptions for each of our participants who were needed to recruit their own people, because we didn't, we weren't doing the agency model. We weren't sending somebody out that we had recruited for them. So they needed to feel comfortable. They needed to hire and interview that individual. We helped to try to keep, some of the liability and other challenges of handling payroll, et cetera, and took those on off of the caregiver's shoulders. And you can refer back to that old presentation on how we designed the Respite RX program that's in the ARCH archives. But that was a very different way of doing things. So yeah, we didn't get everyone through a year, but that was the goal, to see how far we could get them. And we've still got families that are actively receiving respite through our program. Will until the end of December, when our last participant's contract for the year has come up.
Well, great job. I love the title too, because again, going back to terminology and family caregivers may not even know what respite is. I think adding the prescription was really an innovative way to look at that too, because it's medicine. It's for self-care. A family caregiver myself, I do see the benefit of using the RX. So good job. And yes, great presentation. Thank you so much.
Cheryl referred to the previous presentation that she made when they were just kicking off the study, on the design of the study. And Tracy was kind enough to post the link to that earlier presentation that Cheryl did for us almost a year ago now. And then another subsequent presentation that Cheryl also did on using the life course tools to focus on person and family-centered services in their working with caregivers to figure out how they were going to plan their respite time. So we've got lots of other wonderful presentations from Cheryl as well. Lori, I think you had a question.
I guess a
Question-
question
sorry.
comment. Oh, sorry, Cassandra, go ahead.
Well, this is just probably riffing on the RX in your title. Someone asked if anyone had worked with pharmacies to print information. And I remember in Oregon years ago, 20 years ago, Jill, I was so excited about the coalition there actually made bags for pharmacies to use. So it would have the name of the pharmacy. And then on the other side, it had, are you a caregiver? Do you need help? Phone this number. It wasn't huge, but so I've had some private chats going on with people wanting to know more about that. I don't even remember who did it, but do you remember that the pharmacy?
Yeah, absolutely. But I'm not sure we ever saw any data on how effective it was. That was the first state lifespan respite program in Oregon that was established in 1997. So
yeah. But they were doing it, and the only data I have are data that came from just discussions, and apparently it was very successful, whatever that means. But they did get a lot of phone calls as a result of printing the material. Now, what happened to those referrals or the phone calls, I don't know. But it was interesting, and it can be done.
Well, the Oregon Lifespan program was very successful for about 15 years until state funding stopped about 10 years ago. But so the bags probably were very effective as an outreach tool.
Yeah,
Lori,
and the pharmacy gets these bags all printed up. And
Lori, go ahead. I'm sorry.
Oh, no, that's okay, because I was switching topics, so I'm glad we could stay on topic. I just want to comment, and I think Tracy did in the chat, but I would just like to comment about you're bringing in the loneliness shadow pandemic. I think that is profound. I think the information you shared about that and the way you shared it was very compelling. I mean, the whole presentation was, I'm taking notes, I'm looking at the charts, and I have it all in my files, but it's like to hear you speak of it. But I think that's something, we all know about, but talking about that impact of losing friends because you're a caregiver, and just, I really appreciate that you went into some detail about that. And I love the loneliness shadow pandemic. I think that is one of the best new phrases I've learned. And I hope to
you
be
can
able
use
to
it in the
incorporate
Rating
it.
Council
I hope to be able to incorporate it in my work someday soon. But thank you for that, because I think we all think about it, talk about it, but you really addressed it and gave me a lot of really good ideas and food for thought.
That's where the data took us. When we were trying to find the correlation, we have a lot of people in the state that still think if there's a lot of care that's required, that's what determines your need for respite. And our data does not show that. It shows no correlation really at all. So, the ADL approach, I think this data kind of debunks that.
Yeah, that's so fascinating. We had a question from Marilyn Sword, wants to know if you're able to share the survey questions.
Of course, our application goes through our Nevada Care Connection sites, and that's what gets sent to the program. So they capture a lot of the data. The hope was that they were talking to all caregivers and helping to point to some caregiver resources, and that we were only getting the referrals to a GAP program because others were getting referred to other existing programs. But yeah, those are available. The survey, I think we have already, well, maybe not. I'll have to check, Jill, and see whether or not we sent that to you, but that's certainly, you know, it's all part of our Lifespan grant project. So it's all available. We'd be glad to share it. And I can send that, best to you, Jill? And
Yeah,
say,
send it to me, and if you don't mind,
there
we'll share it with the
application?
collaborative, but we'll also, with your permission, post it on the website too.
Yeah, I don't think that's a problem at all. Did I answer the question?
I think so. Let's see what else we have here. Dina has shared some data from, I think this is from the companion pet pilot. And they used the loneliness screen at pre-adoption, and it posted, and during adoption. And after 12 months, they had a 70% of the individuals who adopted a pet had a reduction or significant reduction in isolation after 1 year. So that's interesting data from a pet companion program. Not the same as respite, but during the pandemic, if live people are not possible or accepted, certainly another approach. For those of you who, I'm sure everyone knows this, but, and Cheryl alluded to it, but ARCH did release guidelines on providing and using respite during the pandemic that include decision guides for respite provider agencies to determine if it's safe and appropriate to reopen respite services, as well as decision guides for families on helping them feel more comfortable about using respite services and to determine if they're in a position to start accepting respite. And you also, Cheryl, referred to some experts in the field who have helped develop some decision guides too. And I don't know if you have any links to any of those. Or
No, those are the ones that presented with ARCH that developed those guides. So yeah, they had obviously were right on the ball to get it together while we're still dealing with COVID, right? So
well, that was at the request of all of you out there who said ARCH needs to help us with this. So
yeah,
I don't know.
We don't have any data on the usage of that.
Mm-hmm.
You know, that would have been nice to incorporate, but you know, it's a little late to try to do that now, but we have shared it with our caregivers to see whether they could benefit from it.
In your next study. I mean, I love that Nevada decided to use their Lifespan dollars to not only provide respite services, but to really collect the data so that they could learn moving forward about the best ways to offer vouchers and the best way to help families find and use respite. Just that focus on, and again, for those of you who are on the Performance Measurement Learning Collaborative, great lesson here too, about the importance of collecting the data to help improve the quality of services that we're providing. Any other questions? Comments? Anybody have any updates from their own programs they'd like to share at this time? We have about 5 minutes left. Any burning questions about your own voucher programs you'd like to throw out to the group?
Well, Jill, real quickly, and again, it was from a share from another partner back in the spring. We have been distributing caregiver bags. It was a caregiver box idea, And the comment about thank you from the caregiver for focusing on me was exactly some of the comments we've received. And that appreciation for attention to be on them as a caregiver has just been huge. And so again, I can attest to the qualitative data, the quote you shared about that. They're just so appreciative, and honestly, it's surprising. So many of them are like, thank you for giving me the attention, because so much of care and attention is typically on the care receiver, their loved one.
And what a great impact that must also have on the loneliness factor. If you, of course, know that you're being thought of by someone else, even if you're not getting services, the thoughts alone can be helpful. So that's wonderful. Okay, well, please stay, keep your eye on your inbox, because the leaders of the collaborative will be meeting in the next couple of weeks to set our new dates. Again, if you think of other topics, I think outreach would be a great topic for our next call. And again, we'll try to do these quarterly. So probably in the next 3 or 4 months, we'll schedule the next voucher learning collaborative, unless something really burning and pressing and new emerges that we want to hear about right away.
Jill, one of the things that came out of that, your conference, was that time for living and caring technology-driven app or tool
Yes.
for maximizing benefits from respite. And I would love to have somebody do a presentation on the development of that tool and any data that they have on using that tool. Do you have anyone that could do that?
Well, we could certainly have Rebecca Utz come back and do a presentation for the whole network, though I think she said their testing of the app has really slowed down because of COVID. So they're not nearly as far along in their study, but they do have funding from the National Institute on Aging to study that app. And for those of you who have been with us a very long time, she's a colleague of Dale Lund, who you may all remember from 2010 or 2011, who did that great webinar for us on respite time use and how important it was for the long-term benefits of respite, what the caregivers actually did with their respite time. If it was time well spent and meaningful for them, the long-term effects of reducing stress or improving health outcomes was much improved. And she was a colleague of his, and this app was developed to help implement and improve respite time use. And so she's a great friend of ours and been involved for a long time. So and we've had other requests for her to come back and do another presentation. So I will definitely be moving forward with her to see what she'd be willing to do. She's also going to continue on our committee for advancement of respite research over the project that we're going to be doing for the next 3 or 4 years as well. So we'll be hearing a lot more about that effort. I mean, she's incorporated a lot of the outcomes and the research framework that our expert panel on respite research put forward. Dale Lund was on our expert panel as well. So a lot of her research that she's doing on it is directly related to the expert panel recommendations. Any other thoughts about topics or updates you want to share? Well, thank you all. Thank you, Cheryl, again, for such an excellent presentation. And you'll be hearing from us soon. Stay tuned for the next meeting. And again, if you're also interested in being a collaborative leader, let me know. Have a great afternoon, everybody. And thanks so much for coming today. Bye,
Thank
everybody.
you, everybody. Bye.